we keep hearing about the slogan of universal health coverage. From America to Afghanistan, everybody wants universal health coverage. And certainly, nearly about 7-8 years ago, the Indian government also formed a special group to look into that aspect of thinking about universal health coverage to everyone in our country. A couple of months ago, The Economist magazine's cover page came up with this title, India's Missing Middle Class. Why I'm referring to this is healthcare in general is dependent on the economic condition of the country significantly. According to this article, only 1% of Indians make equivalent of $20,000 or above. But to me, in this information, the most important thing is the bottom half of our country is equal to the destitute parts of Africa. So if we are talking about universal health coverage, we have to think in terms of providing high-quality, comprehensive care to that population too. Only then can we talk about universal health coverage. Almost the same information came a few years earlier from a study by the McKinsey Global Institute, which came up with an index called Empowerment Line, which is an estimate of the minimum economic needs for a household to fulfill the basic needs. It is a composite of 8 different criteria. And this composite of 8 criteria together constituting empowerment line, if we applied to our population in the year 2012, nearly 56% of our population fell below the empowerment line. This is in contrast to the usual poverty line, where the number was only 22%. But to me, I think when we talk of health coverage, we probably have to focus on the 56%, which probably sounds reasonable. So when we talk of health coverage, it's ensuring equitable access for every Indian citizen to affordable, accountable, and appropriate health services. That includes prevention, treatment, and rehabilitation of any residual disabilities. More recently, as you all know, the Indian government came up with a very ambitious and laudable initiative, the Ayushman Bharat, covering the lower 10 crore families for health care up to 5 lakhs a year. To be able to implement that, what is most essential is a robust healthcare system built on the basis of evidence. And that's what I'm trying to give you an example using blindness as one of the areas of healthcare. Blindness globally is a major public health problem. The Vision Loss Expert Group International published about 5 months ago in Lancet the picture of blindness and vision impairment globally. Nearly 36 million people come under the category of blind. To that, more than 200 million are added who have significant visual impairment. Together, they constitute more than 250 million people. But then there is another problem, which most of us, at least sitting in the front rows here, as I see, have suffer from. That is near vision, reading glasses, etc. If you add the problem of near vision to that, the number goes more than 1 billion. So we have to provide services at least to 1 billion people. on top of which the World Health Organization recently is looking at coming, but the status of the World Vision, a report. And I'm part of that editorial committee. When we look at the figure and of everybody seeking services for something like eye care, it's more than half the world's population. India has a disproportionate share of the burden of global blindness, as is so well represented in this cartograph of the global map. Predominantly Asian countries have the biggest magnitude, followed by sub-Saharan Africa. India alone represents 20 to 22% of the global blindness and about the same percentage of significant visual impairment. And in our country, these constitute the common causes that contribute to it. So how do we really address these? How does research help? That's how we began our journey about 20, 25 years ago with what Sharath referred to as a very ambitious epidemiologic study called Andhra Pradesh IDC study, trying to understand the magnitude, the real magnitude of the problem and the major causes that contribute to blindness and vision impairment in our country. Only when we have that knowledge can we really develop appropriate solutions. And this was the information that came out of that. The two major causes that contribute to blindness are cataract, and unknown until then, anywhere in the world, was the problem of uncorrected refractive error. Just imagine not having a pair of glasses contributing to 16% of the blindness in the country. That and cataract together add up to 60%. And if you look at the vision impairment on top of blindness, again the same two, with refractive error becoming number one here. So the third thing that we found out, which was never again, nobody bothered, everybody was doing cataracts surgery, but nowhere in the world has anybody stopped to look at the outcomes of that cataract surgical intervention. So in this study, when we looked at the interventions in two rural populations, the district of Adilabad and the district of Mahbubnagar, 34% who underwent cataract surgery in Adilabad went blind, and 43% in Mahbubnagar district went blind. And the other figure that is next to it, I'll come to a little bit later. And the same study demonstrated even in the city of Hyderabad, 24% who underwent cataract surgery went blind. So not having any knowledge, we pay a big penalty. And based on this, the National Eye Institute of NIH funded the World Health Organization to replicate these studies around the world, in Nepal, in China, in Egypt, in Chile, and it's the same story all around the world. So from this study, the significant things that came out were uncorrected refractive error is a major problem, very simple problem. We have effective and cost-effective solution already available. We don't need any more research for that. Poor visual outcomes after cataract surgery because of lack of attention to quality. And then there are a lot of posterior segment disorders of the eye that are contributing to blindness. And lack of affordability is a big barrier in seeking care. Based on this, this is the model that we have created. While we are a top-down model, we started in Hyderabad in 1987 with a center of excellence. At that time, the vision was very limited to replicate an academic eye center that I saw in the US. treatment, education, and research. The only thing we added at that time was to have everything under one umbrella, which is unusual, which never happened with any other academic center in the world, was to incorporate even rehabilitation of irreversible blindness as an integral part of our activity. But only as we went by 5 years, 6 years later did we realize the enormity of the issues that we are confronted with in our country. And we decided to plunge in and develop a model. And armed with the information that this epidemiologic study gave us, we developed this model, a 5-tier structure. That is actually a model for comprehensive or universal eye health that provides comprehensive eye care, commitment to quality, because we develop permanent facilities in remote, rural, and tribal areas. You have continuity of eye care. These are not eye camps. You have continuity of eye care, good infrastructure, well-trained human resources. And then it's closer to the doorstep of the people with community participation. At the very bottom, we deal with a population unit of 5,000 people with, who are volunteers, healthcare workers, ASHA workers, etc., to tackle the top two: detection, cataract and refractive error. As we have already discussed, these two together constitute 60% of the blindness, 86% of the vision impairment. These two together can be handled, beginning to be handled at this level through screening programs and surveillance post-operatively of everybody that had cataract surgery in that particular community of 5,000 people. In the recent past, we have a technology innovation center in our institute. The kids, brilliant engineering kids, came up with this tool with a simple telescopic kind of thing. You could test for refractive error in the rural communities or any community screening tool within half a diopter of accuracy. And this is going to be applied all across the world now as a tool, and our vision is to place it in the hand of every school teacher around the country and around the world eventually, so that every year, at the beginning of the year, the school teachers can test every kid. The next is a concept we came up about 25 years ago called vision centers, the primary care centers in remote, rural, and tribal areas, where the major vision disability problem, refractive error, can be tackled by a 1-year trained high school graduate. And then we did a series of studies on the functioning of these things, actually resulting in 2 PhDs from the University of New South Wales in Sydney, that actually these kids with 1-year training can match an optometrist with a 4-year degree in the ability to test for refractive error and give corrective glasses. And they can detect all potentially blinding problems. Simple infrastructure in a village. In most villages, increasingly, we are getting donation of property from the local people to set up the vision centers. So this is the system that we are working on. And as I already said, 2 PhDs, and we were delighted. A couple of years ago, one such center started in Majuli Island on Brahmaputra, linked to one of our partner hospitals in the next city. And we also began to leverage technology, taking pictures and then sending it to the higher levels for any possible diagnosis whenever there is a doubt. We now have 174 such centers spanning across the 3 states and a little bit into Karnataka around Ballari area. 10 such centers are then linked to a secondary level eye hospital with 1 or 2 ophthalmologists and a staff of 2. Here, the focus is on the cataract. This one, the 2.9 and 3.4% is when you set up the proper system with good quality, the 34% drop down to 2.9, and 43% dropped down to 3.4% in terms of postoperative outcomes. Only 2.9% in this center and around 3% have postoperative problems and blindness when we have the proper system. So we have all the diagnostic services, medical treatment, and cataract surgery are the predominant thing initially. Then based on, again, what Sharath pointed out, our clinician scientists, along with some basic scientists in stem cell biology, began to look at how do we take the benefits of stem cell transplantation, the surface transplantation, to the remote rural areas closer to the communities where the most problems are. Dry eyes, sequelae of injuries, chemical injuries, etc., and also retinal diseases, glaucoma, and corneal disease. So we have begun to do it, and in the area of corneal transplantation and stem cell transplantation, we now have a system based on our clinical research, outcomes research, and also what has happened in our laboratory. A corneal specialist of our faculty travels to these centers once a month to perform the surgery. Donor cornea was supplied by our central eye bank, which is the biggest eye bank in the country. And by the way, Hyderabad has been the only city with the country with no waiting list for corneal transplant for the past decade. That's because we set up a system, we did research on the functioning of that system of hospital cornea retrieval program in every major hospital. And the concentrate from the bereaved families is 75%, higher than the American hospitals. So people are willing to donate corneas. And because of that luxury, we can supply the villages, and then the ophthalmologist there, our ophthalmologist, can provide the follow-up care, and then they are connected through technology. Here is an innovation and engineering research that came from University of Miami Bascom Palmer Eye Institute, a robotized slit lamp where the patient is sitting in the village, putting his chin on the slit lamp microscope, and our cornea specialist sitting in Hyderabad is examining that particular individual. So application of engineering research in a remote setting to provide high quality care to somebody living in a rural area. At the next level we deal with the tertiary care. This is where the research comes in. Overall, L.V. Prasad Eye Institute has these 10 functional elements today. It is the interlinking of all these functions that make us tick and make us what we are today. And when we come to research, these are all the components of our research effort today. We have a fairly large research group, and we have the tradition of each of our clinicians having dedicated research time ranging between 20 to 70%, depending on their level of interest. We have some clinician scientists who deal with patient care only one day a week. The rest of the week they are in the labs, they are working on doing research projects. Because of that and the commitment from the institute side, we could create a culture of research, developing a quality team, and we have lots of collaborations with leading Indian and international institutions that has contributed to productivity of our group in a significant way. In the area of stem cell biology and regeneration, we are working on resurfacing the cornea. The entire corneal regeneration, we are able to grow individual layers at this point. We are now trying to grow the entire cornea. And we are also big on biosynthetic cornea. Various projects are in place now. And using iPSC technology, we're also trying to see whether we could transform skin cells into retinal cells, and that work is progressing quite well. This is the novel technique of simple limbal epithelial transplantation called SLET, which is now being applied all over the world as a technique with eliminating the need for a stem cell laboratory. In vivo, taking small pieces of the limbal tissue from the healthy opposite eye and transplanting on the damaged eye. And this is the postoperative result that you see on the right. The left eye is the one which was damaged, vascularized cornea, surface irregular, and the right side of the picture is the postoperative picture of the same person. And the results are very, very satisfactory, over 70%, gaining significant improvement in visual acuity, and the long-term survival over 5 years is again 70 to 80%. We're also working with some artificial synthetic materials to allow the regeneration and promote the regeneration of stem cells, and this work is going on in our CGMP, CGLP facilities that we have created about 5 years ago. We're also looking at the limbal mesenchymal cells to control the scarring of the cornea, as you can see here. The upper part of the slide indicating a central corneal scar. With the injection of the stromal cells, mesenchymal cells, you could clear the corneal scar. By doing all this, we decrease the need for corneal tissue for transplantation. Earlier, for the scar that you are seeing here, the traditional treatment was a complete corneal transplantation with all its attendant risks of complications, follow-up care, etc. Whereas a simple injection like this could eliminate that need, and the scar can be cleared with significant improvement in vision. In the area of infectious disease, we are looking at antibiotic resistance studies, rapid identification of pathogens, and how do we use various antimicrobial agents and improve the drug delivery systems. We are working with microneedle patch kind of technology as one of our projects, and the results seem to be quite promising. And just a couple of weeks ago, a group from Israel again has expressed interest to take this technology to the next level. Yet another area that we are very active is vision psychophysics or optics. And here we are looking at people who need corneal transplantation in one eye. The transplant is clear, successful. The person sees through that eye very well, but are the two eyes working together? This was the question we asked, and we found out there is a significant difference in the way the aberrations are between the two eyes. And then we realized unless we correct with the contact lens, the two eyes cannot be brought together. If you don't have the ability to fix them with contact lenses in the postoperative period, operating in one eye for corneal transplant would not make any sense. So there again, you can eliminate the need for doing a corneal transplantation. So going back to the application of technology, in the screening programs, tablets, and then you get all the data, and that data and evaluation and the data analysis will lead us to better information, and that could be applied to advocacy that leads to policy. We are also using machine learning technologies to predictive analysis for the future of the outcomes of various interventions. Like if a child is -2 at age 4, what would be the power of that child at 12? Who is going to become -8? Who is going to remain at -3 or -4? These are all the things that we are going to be able to do in a few years using the machine learning. We are applying the AR, VR, HoloLens, Microsoft HoloLens to develop teaching tools for anatomy, surgical techniques, etc. One of our pediatric optometrists, a PhD from Harvard, she developed this perimeter. For the first time in children, we can actually detect the visual field abnormalities in a child. So with all this is the kind of scorecard, nearly 26 million touched. We are in 197 geographic locations. The model is being replicated in many parts of India and in many other developing countries right now. And in terms of research, this has been our record. Over 2,200 publications in peer-reviewed journals, 45 PhDs, and 4 Bhatnagars, 2 Ranbacks, etc. So the combination of a number of research areas, epidemiology, clinical research, basic laboratory research, and I didn't talk about it, we also have a patient-reported outcomes research unit that again is very helpful, and health systems research. Together, with appropriate leverage of technology, we could create a model, a system of healthcare delivery that could perhaps be replicated in other areas of medicine to provide the appropriate care, the real universal health coverage. And I want you to see this. I hope that our efforts in future will eliminate the need for such perilous journey to any child to provide health care to his or her parents. Thank you all so much.